All right. Hello there, and welcome to Lexicon India's Instagram page. Good evening to everyone watching in India. Today, we are starting with a session with Dr. Varun Agrawal. He has a page called Ed4Med US, and he is our guest today in this episode or this live. We're just waiting for him to join in. Okay. Hello. Yes. Good morning, Dr. Agrawal.
Hi, good morning, Dr. Adil. How are you?
I'm doing good. How are you?
Fantastic. Good too. Thank you.
Yes. All right. So I'd like to welcome everyone watching this and everyone who's going to watch this later on the Instagram page. I would really like to introduce our guest today. Dr. Varun Agrawal here is a board-certified MD physician and nephrologist, a member of the fellow of the American College of Physicians, and a fellow of the American Society of Nephrology. We welcome you today. Dr. Varun Agrawal provides personalized consultation services and guidance in efforts to improve a candidate's chances of matching into a U.S. residency program. He is an IMG himself and currently is an associate professor at a teaching hospital as well. He has interviewed both US and IMGs for the residency positions. He has published research with a high impact factor and contributed on a book that was published in 2008 called Acing the USMLE and the Match, a guide for international medical graduates. Welcome, Dr. Varun Agrawal. And this is an episode in the series USMLE with Lexicon. And today's topic is US residency, the good, the bad, and the ugly.
Thank you, Dr. Adil, for the introduction. Hi, everyone, and thank you, Lexicon, very much for inviting me. Glad to be here speaking to you and your audience. You know, whenever I interact with medical students and graduates from India, it always reminds me of my wonderful days in MBBS when I was at Jipmer Pondicherry. So it's wonderful to be connecting with you all. And so I'm Dr. Agrawal. I'm a practicing nephrologist for the last about 12 years and also a faculty member in a teaching hospital. Really love to interact with medical students, residents, and fellows. Now, I started Ed4Med US about 4 years ago. This is a service that I started for international medical graduate, IMGs, and to really help them, improve chances of getting into US residency. I'm sure many of you would have heard about the 2023 match. It just happened, last week, and very excited to have worked with many hardworking IMGs and who will start this July and help them, that I could help them match into residency. My focus mainly is on, not really on USMLE tests because there are so many excellent resources, but there are other parts of the application like the personal statement and the practice interview, which really can make or break one's chance of getting into residency. And you can look at my website for the many courses, all the posts, reels, and YouTube videos I have out there. Coming to today's topic, U.S. residency, the good, bad, and the ugly, just like the movie title, I chose this topic because I really feel U.S. residency is of great interest to MBBS students and graduates from India.
Yes.
I looked at the statistics. There are about 35,000 U.S. residency positions, and about 7,500 are those positions are taken by international medical graduates. And guess where most of the IMGs come from? They come from India. About 25% of the IMGs come from India. That just tells us about the huge interest and the high level of interest that's there among, MBBS students and graduates to take this journey to US residency. So why did I choose this topic? Now, when I started, when I was preparing for my residency, this was way back 2004 or 5, I really had very little information on what residency, what's it going to be like. And I was basically just following a very close friend of mine. It was a growing trend in 2000s and still is. But if I could go back in time and, I wish my younger self knew about what I'm going to talk today. And the goal is to give an overview of US residency so that when your audience, the MBBS students and graduates who are thinking of doing rotations, electives as students, or they're going to be doing these observership externships as graduates, they're not going to be in for a surprise once they have, some of the information that I'm going to share with them in this talk. So let's start with the good aspects. What are the, good things about U.S. residency? Now, certainly when I first, got into residency, even a few days before residency, I really didn't know what to expect. All I knew it was going to be busy. All I knew that, work hard and play hard. But just a few days into residency, it became very clear to me why U.S. residency works so well. And the reason is because it's very balanced. What do I mean by balanced? Balanced in terms of the clinical work that you have to do, and then having time for learning, your own education, time for research, and so forth. And because the work hours are very tightly regulated by ACGME, the Accreditation Council for Graduate Medical Education, think of this as the NMC in India, the National Medical Commission. And when you have your daily rounds, you have your daily progress notes, they are very structured. There's a very interesting template called the SOAP format, SOAP, Subjective, Objective Assessment and Plan. I feel this is a very, very nice approach because it really forces you as the resident to address every concern, every patient problem, lab abnormality, and so forth, and what you're doing about it. It really forces you to come up with a plan. And as you go on to your second and third year and so forth, you just get faster at it. So for example, if someone has a COPD exacerbation and is a diabetic, your plan would be something like, okay, I'm going to start them on glucocorticoids, antibiotics, bronchodilators, home oxygen. But at the same time, what are you doing about their insulin regimen because they might get hyperglycemic? So what are you doing about their hypertension control, their deep vein thrombosis prevention? So it really forces you, and then it becomes very, much internalized by the time you finish residency. And so that's a very nice approach in U.S. residency. You also get options to choose your electives. For example, I had an interest in nephrology, so I was able to choose a 2 to 4 week of elective, even in my first year and second year. And so they really encourage you to, pursue your interests. Evidence-based medicine, that's huge. The whole practice in U.S. Residency and even beyond is evidence-based medicine. Every computer in the hospital has UpToDate, which many of you may know is really a wonderful resource to find out, okay, what antibiotic should I give, what dose should I give, or what should I do in this situation, what's the evidence for this therapy versus not the next one. So it's really very much encouraged and practiced every day. So you really, by the end of residency, become very much aware of how to take care of patients as per the standard of care, as per the current evidence. The programs really encourage you to go for conferences, and so that works out well. You have CME money to funds to help you go for that. Last one or two more points I might say is the fellowship. The fellowship options are amazing. Once you go into residency, many more doors open for you if you want to specialize in a certain specialties, even specialize even further beyond that. Lastly, a lot of advances are happening in education, in residency education. Point of care ultrasound is really, really picking up here in US. Palliative care is another one where you talk about end-of-life discussions, patients with terminal illness. That works very well. So because of some of these reasons that I mentioned, the well-structured, the well-balanced curriculum, what's interesting is you don't need to be in a top-ranked hospital to be a very good internist or a psychiatrist or pathologist. So because, again, ACGME regulates, okay, you know, how many ICU months are needed for residency, how many procedures you need to do, how many line placements, what's your research requirement. So that's uniform. And so, you know, so for example, you don't have to be at a top-ranked institute like Harvard or the Ivy League institutes to really be an internist. You can go to any hospital. From my own perspective, I trained in a community hospital, not really a university hospital, but that still worked out great because in the end, the ACGME regulations make sure that, you know, that the minimum standards are adhered to, and that works very well. So let's talk about some other good aspects of U.S. residency, and that is the people. By people, I mean it's the patients as well as the physicians. Working with the people, you know, I'm sure we all realize nowadays that to be successful at work, it's not really, you know, the website or how fancy the building is. It's mainly the people that determine how, you know, how you're going to like the work.
That's correct.
And the patients I've worked with, they're very appreciative, they listen to you, they follow your instructions. Many of them respect you. If you respect them, they'll respect you. It's as simple as that. I've never had or heard about any situations, any assault situations, any attacks based on how I look or how, you know, where I'm from. That's never really happened with me. Work culture is very, very professional. You are really, you will be responsible for all your actions, held accountable. There's a wonderful word called autonomy. As you move forward in your residency, you will be expected to have more autonomy over the decisions about your patients. And that, you know, sometimes it can be scary to kind of have that much autonomy, but that's what U.S. residency really allows you to grow, have that professional growth throughout your years of residency. There's another word called leadership. So when you have this autonomy, you build leadership skills, and that's a wonderful thing to have. Even if you have leadership before residency, which is something I like to tell my residency applicants, it really, you know, allows you to work very effectively during U.S. residency. Let's go on to the other aspects of residency, which are the bad aspects. Let's talk about that. You know, I really want to give a very balanced view of U.S. residency training. U.S. residency can sometimes be inefficient. There's a lot of documentation burden in your day-to-day work. Interestingly, there was a paper, like an Annals of Internal Medicine 2016 paper, where they really showed that for every 1 hour of patient face-to-face interaction, 2 hours are spent in documenting, ordering stuff, following up, and so forth. So there's a lot of EMR, electronic medical record burden, and so much is written about inefficiency. You must have seen some of Dr. Glaucom Flecken's YouTube shorts where he talks about internal medicine residents admitting an orthopedic patient with hip fracture. So some of those things do happen. I guess it's all a part of learning, and you know, just do your best. No system is perfect, but you know, sometimes it can feel a little bit on the inefficient side. And another bad thing sometimes, you know, I feel or I see residents talk about is sometimes they feel, they question, you know, how effective is my care for my patients. That is, so, you know, when I saw my first patient who in the ICU with sepsis, with pneumonia, who was on tracheostomy ventilator, had a PEG feeding tube, sometimes, you know, it made me wonder, are we really helping the patient or just prolonging their suffering? You know, other instances come in mind. You're talking about a patient with lung cancer whom you're talking about chemotherapy, but at the same time, the patient is smoking. So sometimes you wonder, you know, I mean, you really want to give the benefits of modern medicine to your patients, but, you know, sometimes it gets a little bit tricky. And personally, I really look up to those physicians, including mentors of mine, who had the guts to tell the patient and their family, you know what, it's just not working. We're going to have to stop and we're going to have to let go. And that's what palliative care is all about. Sometimes you also worry, you come across these situations about costs of medicine. Now, this doesn't really apply a lot in U.S. residency because you're working in the hospital, in the clinic, so you don't experience much of that. Like the other day, there was this question about this medicine called tolvaptan. That's a medicine for hyponatremia, those aquaporin inhibitors. Or there's something called rituximab for vasculitis. So sometimes it gets difficult to have those provided to the patients, not really in the hospital, but outside the hospital. I don't think you have to worry too much about that during residency, but it's something that needs to be taken into account when you're practicing.
Okay.
Let's go to the last part, which is the ugly aspects of U.S. residency, which can get interesting. And the first, I would say, is the whole residency application process itself.
Yes,
it's very complex. Very complex, starting with the USMLE exams, then, getting your rotations or clinical experiences, applying, interviewing, then making this match order list, going through a process called scramble or SOAP. And it can be very daunting, very frustrating at times. In fact, someone just posted on Twitter a few days ago about the cost, and they said it was about $11,000 for the applications, about like 9 lakh rupees for just the application process, the exams, the registration, the programs you apply to, and so forth.
That is a huge
It doesn't include
amount.
the cost. Yeah. It doesn't include the cost of when you're physically here in the U.S. to do your 3 to 6 months of clinical rotations, your U.S. clinical experiences, because you need letters of support. So, and then, you see some of these applicants I've worked with who unfortunately did not match. And then there's not much transparency. So you don't really know what didn't work out. What should they do next? You can make an educated guess as best as I can, which is something that I help my residency applicants with. The last part I would say that's ugly about U.S. residency would be something called burnout. Burnout is a concept. It's a topic of great interest of mine. And there's a huge amount of burnout among residents. Maybe even about 50 to 60% have, in surveys done, talked about burnout. It's not clear if it's like a U.S. residency thing or it's internationally done. It's an international problem. But, whether it's the whole practice of medicine, how patients are demanding of us, or our own, role in this burnout, it's still not very clear. Only one thing I can say that really works out is having a good network, a good social support. That's what it's called, having your friends, your family, your mentors, attendings, whom you can freely talk to and discuss. That's really the one big thing that goes against burnout. So with this information, I talked about the good, the bad, and the ugly of U.S. residency. I really hope this just gives you a very quick, a very superficial view of what to expect when you do your rotations or even your residency. If I have to end this talk with one piece of advice, I would typically say, work on your communication skills, work on your writing, your speaking, even talking with people, from other countries, how you talk with them, how you exude confidence. That really plays a huge role in success. And that advice just doesn't applies to U.S. residency, but also applies to if you're practicing in other countries. The U.S. work culture is very extrovert, so you have to force yourself to be bold. This is one very good advice I give to all my applicants, residency applicants I work with during an interview. So at the end of the interview, they'll say, something like, they'll end the interview, I think I'll be a good asset to your program. And I tell them, you have to be much bolder than that. You have to force yourself, you have to practice and say, I really believe I'll be a very good fit for your program. So I really, help them practice. And then I really feel that confidence does make a difference in how you appear to the other person. So, for example, if I get these requests for, hey, I'll get a request from a medical student, do you have any research projects that you're doing? So I'm not going to reply to that. But if someone says, I understand you have an interest in kidney stones in bariatric surgery, can we write a review paper together? Can we write do a systematic review? Then you're being very personalized and very, bold about approaching me, and then you're very likely to get a reply from me. So this is what I was talking about, really improving your communication skills. And again, just doesn't apply to US residency, it applies to every aspect of your life as a doctor. The harder you work, the communicate and network with others, the more your chances of professional success. So I hope, just wanted to show that there's a learning curve in US residency. Many of you have done it successfully before, and many of you will. So with that, I'm happy to take any questions that your audience may have, and certainly feel free to DM me or WhatsApp me, and happy to answer any questions.
All right. Okay. Thank you. Well, we have our audience. Everyone who is watching this, feel free to ask any questions at this time. We did ask our followers on Instagram through stories if they would like to ask you anything in particular. So I've written those questions down, and I just wanted to share these with you and share your views on these questions. Okay. So just in line with what you mentioned about the ugly. So one of the major questions that every medical student has thinking about applying for the US is it worth it? So here we have hippocampus_speaks. He asked, is it worth it to clear USMLE and invest that amount of time and money to do residency in the US? So I know you've mentioned the good, but here we have this main idea, which is this cost worth whatever will come after it?
So certainly, from someone who has gone through the whole process and has been, like I said, practicing for 12 years, I certainly do believe it's worth the cost.
Okay.
Now, the thing is, it all depends on what that person, wants out of his or her career. For example, if someone is like, okay, I really want to go out of my home country and really want to be a very nice subspecialist, proceduralist, maybe even into research, So then the US residency is a very wonderful idea, a very wonderful investment, as you meant, the word that was mentioned. The return of investment is very high. Now, if the MBBS student or doctor is like, okay, I want to go to US, study there for 3 years, do my residency, and then come back to my home country, then I'm going to say I don't believe that's a very worthy investment, because the styles of practice are very different. I'm not saying it's impossible, but it's very much different. So I would say look at your long-term goal, and if your goal certainly, if you have family, you have friends in the US and really want to build a career, and be here in the US, then certainly it's a very worthy investment. And certainly, but do also explore other, other countries also. Like I said, no system is perfect. Like I mentioned, that's why I talked the bad and the ugly aspects of US residency. And like I said, many people are still, matching into US residency and doing well. And so, that's my answer to that question.
Okay, thank you. All right. We have just a few more questions. We have one question from Pranita_425 here in our chats. She has asked, how can you network when you have no contacts in the US?
Right. Yeah, that's a very tricky situation. And what I feel is certainly, start with folks from your own med school. Maybe if you had a certain graduate, people from your med school, much senior to you, who have gone into the US, definitely reach out to them. What's very interesting is if a residency program took a graduate from a certain med school, say in India and so forth, they're very likely to take another graduate from that med school, if that doctor did very well. So that's one. Then you have to keep asking maybe your friends. That's kind of family, if you have family relations here. A lot of, I've heard about how folks, the MBBS graduates, they want to do these observerships, externships.
Hmm.
It's through family. They ask, can you ask your doctor if I can shadow them in the clinic? And through the family, they're able to get into these observerships, externships. One very some people, they do this research positions, which I think is a very nice way of networking. So how do you find those research positions? That itself is is a topic of its own. But if you're able to get into like a research assistant position in the US, in fact, I've seen some tweets about looking for visa sponsoring positions. That really opens up doors for networking. It is tough. I'm not going to lie to you, but that's what you have to, that's why I was talking about communication skills. Really, really, be bold to approach them. Don't be modest. Take credit for all your hard work. These are three ways I can say right now. And it's interesting how even in social media now, people are making connections on social media.
Mm.
And I'm not going to say that's how they are able to get into residency or get into these positions, but I think having a presence in the social media is also working out as
Mm.
one option of, connecting with some of these attendings. On Twitter, there are so many, attendings out there. All these research assistant positions get posted there. That might also be another way. You're going to have to keep trying. There's no real one hard and fast rule about networking.
I see. That is a wonderful answer to a very difficult question. Yeah, I think Dr. Agrawal summarized it very well for all of us. I hope, Pranita, that answers your question. So we'll move on to the next question. We have from Arya Srinivasan. She asked if there is one important criteria for selection of candidates, what is that?
So the criteria, there are so many. Certainly, I will say one thing, that having an attempt on your USMLE step 1, C2, step 2 CK, that really, really makes it very, very difficult to get these interview offers. So please do your, while I don't want to say that the test scores, they are very, very important to at least, get into this interview,
Hmm.
into the stage of getting interviews. So at least definitely work on that. The second point I would say is your letters of support. Nowadays, the U.S. clinical experience and the letters of support are becoming so important that programs are really, really looking at that. Because, let's think from the program director's perspective. They have, say, they have now like hundreds, thousands of applicants. If all of them have good USMLE scores, how is one going to differentiate these applicants? They're going to be differentiated by how your letters of support, your personal statement, and that's the best you can really do to decide whether to invite them for an interview. So until the point of getting an interview, I really think the scores and the letters of support matter the most. Research is kind of plus or minus. If you're going to be practicing as an internal medicine resident, then it's more important for me to know that you can talk to patients, communicate with them,
Hmm.
talk to your attendings, ask questions, present things, rather than, whether you know how to do a logistic regression analysis and so forth.
Hmm.
And but once you're past that interview stage, it's all the interview performance that really, determines where you're going to be ranked.
I see. So, is the confidence with which you are present in this interview, how you show yourself, and how eager you are, what energy you bring to this interview. And
Absolutely. And, having that enthusiasm and clarity in, okay, talk to me about a leadership position that you've had,
mhm,
or talk to me about a difficult patient situation, and, being able to present it in a nice, logical, clear communication. That's how, program directors decide, okay, this person will be a good fit for our program.
I understand. All right. Thank you. Or moving on to our last few questions, we have Prerna Khirajani. She asked, how much independence does a postgraduate year one get when it comes to taking patient responsibility?
Oh, a lot of independence and autonomy is given. Now, when you say autonomy, you're always
Yes.
going to be supervised. Okay, that's another wonderful thing about U.S. residency. You're never going to be left alone. In fact, I always encourage my residents to ask for help. Never ever hesitate to ask for help. Not
Okay.
asking for help is going to be something negative against you. And you know, uh, like I mentioned, I also am an IMG. I also did my training in India. So the work culture was, let's not bother another person. Let's not ask questions. But that's very much here. You have to feel free to ask questions. You should never ever be hesitant because much more bad things can happen if you don't seek out help. So in
Hmm.
terms of autonomy, yes, you are the first one seeing the patient, coming up with a plan, putting the orders, and of course, talking with your resident and your attending about your plan. I've had these situations when you talk about autonomy. I still remember in my first year, there was a situation where there was a patient in the emergency room with sepsis and urinary tract infection. So it's a very interesting story. And I asked, when you talk about autonomy, when I talked with the ER attending, he was like, "Nah, that's fine. Just treat this patient with antibiotics." But
Hmm.
then something didn't seem right to me, and because of this autonomy, I was able to myself reach out to the urology team, saying, "You know what? Can you come by see this patient because I don't know what to do with an infected stone?" And then interestingly, they just took the patient right to the operating room, I think the patient did well. If I have to think about it,
Hmm.
but that's autonomy. I'm not saying that you're going to do things wrong things for the patient, but you're always going to be supervised. You always have a resident to talk to. You'll always have an attending to talk to. They'll let you do your thing. If you want to choose a certain antibiotic, a certain dose, they'll ask you what antibiotic do you want, and you will tell them. And so that's very interesting you asked that question because when you talk about autonomy, I always tell my residents, don't, if someone is seeing a patient in the clinic with, say, UTI, urinary tract infection, I tell them, don't ask me what antibiotic should I give. The resident should be telling me, I think Bactrim or the trimethoprim sulfamethoxazole is a wonderful antibiotic. That's the first line. Is it okay that I prescribe it? That's how the approach should be.
Hmm.
That's a learning that's there. Not just asking me for what I think, but the autonomy happens and the growth happens when you come up with answers and check, if that's right or wrong.
I see. Okay.
Yeah.
So, Prerna,
Procedures
I hope.
also,
Yeah.
procedures also, there is supervision, for central line placement and all. And after a certain number, then, you're kind of on your own, but you're always there, you're always there to ask help from the attending if you have questions about the procedure. So it's a very wonderful balance between autonomy and supervision.
Yes. I think that's the healthiest method that we could have in teaching someone these skills, where you balance supervision with autonomy as well. So that's excellent. Then we have another question within the live chat from May I Know. She asks, there are very few rotation opportunities available for IMGs. Does it really matter if the experience is outpatient based or inpatient based, since we have only limited options for US clinical experience?
Um, so the way I answer these questions are, there's always an ideal situation and there's less than ideal situation. Ideal situation would be to have both outpatient and inpatient
Hmm.
experiences because in the inpatient experience, that's when you will be with the resident team, you will be rounding on patients in the hospital, having these discussions. When you're in the clinic, you're kind of just there with the attending. Now, I'm not saying that, so both experiences kind of complement each other. So that's like the most ideal situation to
Hmm.
have. But, I understand that, yes, it's difficult to get rotations. If you're getting only outpatient, I would still say go for it, because a lot of the skills can still be demonstrated in the outpatient rotation, such as how do you talk to patients, how do you take history, how do you talk with an attending, how you present to the attending, how do you present a talk on a certain, topic that's of interest to you. Those skills will still be valuable in residency, and if you do well in that rotation, that outpatient rotation, that will show up in your letter. So I would say keep trying if you can find inpatient to complement your outpatient experience. But if you're just doing outpatient, go for it.
All right. Okay. Thank you. And our last question that was asked by Kirat Korbular, she asked us how you've answered this before, but just for the sake of her question, how are international medical graduates treated in the USA?
Oh, treated very, very well. I mean, I myself am an international medical graduate. Like I said, a quarter of the practicing doctors, 25 to international medical graduates, are treated very well. And again, it all depends on how you are, presenting yourself, how you're respecting others and working with others. That's all that really matters. Which country you're from, what your how you look, how you speak, that doesn't really matter. And like I mentioned, it all depends on how much effort you're willing to put. If you keep searching on the internet, you will have so many international medical graduates in very good leadership positions. Dr. Adil mentioned one of my achievements, FASN, Fellowship of American Society of Nephrology. Yeah. The president of that American Society of Nephrology, his name is Dr. Anupam Agrawal from Alabama, international medical graduate. So people can really work very hard. The system encourages people working hard and moving up the ladder, moving up the hierarchy, and doing very well. So they're treated well. I would not worry about concerns about, if the question was about racism and those kind of situations. I've not experienced it. And I've not really heard any of my colleagues also experiencing that. You will, of course, there will be some situations, very unpleasant situations may happen, but that's super rare. I would not worry about that. I would just worry about doing your part, be accountable, be responsible, work hard, and then you'll be successful.
I see. All right. Thank you. Well, that was the last of our questions gathered from our stories and from our audience watching at this live session. A personal question that I had, according to the same process, I myself graduated in 2020. I took my step one, I cleared it, but due to COVID, like a lot of us, I decided to discontinue the process or wait till a better time. So since then, step one has become a pass-fail exam. Even though I had a 3-digit score, and more importance is given to step two. Could you please help us understand how important step two is now compared to before, and if it is still significant to do exceptionally well on this exam, or does it discourage someone, or maybe they should rethink if they didn't score that highly on their step two?
So, I've worked with applicants who have had attempts on their step one or step two CK. I've worked with applicants who had a long time since graduation. And, whenever someone asks me, should I, keep going? Should I still go ahead and apply? There is no real clear formula on, who is going to be successful in matching. You can just try to strengthen your application as best as you can. So if you have done your step one, the 3-digit passing score, I mean, that's all that matters right now. The step two CK, yes, I highly suggest take the exam when you're most prepared, when you have, there's so many wonderful resources out there and so many Q banks. Be very well prepared for it. Try to score your best. I would say, like I said, make sure you pass it on the first attempt for sure. make sure you're at least hitting the average or beyond the average. Every year, the USMLE, they give this graph about what's the average score. 240s or so, I believe, is the average. So do your very best to hit average or more than that. But don't be discouraged if you got 260 instead of 270. It doesn't really matter. Once you hit average, then it's all these other parts of your application, your letters, your leadership skills, your personal statement, and those aspects then start to matter more. So, and then I've had these some applicants who, besides their attempt, they're in the U.S., for family reasons, their whole family is here. And yes, it may take some more time. It may take more. People may not be successful the first time, maybe the second time. They try these other ways to make up for their application and, still end up matching, which is wonderful, which is perfectly fine, because you're very right that the score does not define how we're going to be as a physician. The score is just one aspect of it. So, but also I would suggest is try not to delay a lot since graduation. Try to, if you really want to go into U.S. residency, the sooner the better, because then you have a lot more explaining to do what you've been doing since graduation. The way the program directors think that, they might think, okay, maybe this person's not sure about residency. They really want you to be very focused, very clear about U.S. residency rather than, okay, I'm going to give it a try. They really don't want any of those kind of approaches. So, your whole application that, okay, this person has just done internal medicine rotations, internal medicine research, or leadership skills, and that's what you write in your personal statement. That's what strengthens your application.
I see. So dedication towards your goal, clearly showing that you are interested in this one particular thing, instead of displaying that you have sort of 1 foot through the door, but maybe not the whole way through. Just be confident through the process, and the process might be different for different people. So thank you very much for
The word
that.
is consistency. The word is when I look at the application, when I'm preparing myself for doing the practice interview on the applicants, the one thing that I look for is consistency. So if I see that this person has done rotations, say in psychiatry, but is applying for internal medicine, I make it a point to ask them, why are you doing this psychiatry rotation? Because you say you want to go into internal medicine. And then how you confidently answer that, probably that person might say, I came to US and this was I really was looking hard for a clinical experience. This was the first opportunity that became available, and so I grabbed it. Then that makes perfect sense. But if you're like, say it in a way that you're not sure about it, or you may have applied to another specialty, then it becomes very tricky. And so to add to that part that you said, be consistent and dedicated, also make sure you have identified one specialty to apply to.
Okay.
I do know that some applicants apply for internal medicine and family medicine, or internal medicine and psychiatry maybe. It gets very, very tricky, and the program directors can sense it if you're not committed to that specialty. I mean, your application will say that very clearly. So what I'm suggesting, when you're putting the dedicated effort, make sure it's all dedicated to that one specialty, and then that's what makes your whole application very consistent.
Okay. Thank you. All right. Well, we have one last question. Someone has asked at the last moment here before we close for today. We have Sheetal Sarangi. She's asked, is the gateway for US closing by 2024? I'm not entirely aware of the context, but she has asked, is the gateway for US closing by 2024?
So I believe that question is about what's happening, what's going to happen in the next few years is that, all the med schools outside US, they need to go through this accreditation process. Our graduates from this med school, say in India, Pakistan, Nepal, are those graduates accredited to do residency in US? Right now, all it is if the name of your med school, med college shows up in this list of colleges, it's a world list, then you can apply for residency. But now what I believe they're talking about is what's going to happen if their medical college is not accredited, and that is a very tricky question. I'm not going to say that the gate's going to close and so forth. It remains to be seen. I have no way of predicting how things would play out. All I can say is, just keep preparing as best as you can, and in the last moment, if your college is not accredited, maybe it might take a little bit more time for that recognition to happen. But I wouldn't think of that as a reason not to pursue USMLE. If people want to wait a little while and see how things turn out, that's fine too. But I wouldn't lose sleep over it. Let's just focus on. That's why I was saying, if people have graduated, go and start applying and get into residency sooner rather than later.
I see. All right. Thank you so much, Dr. Agrawal, for joining us here today. You've excellently explained to us exactly the pros, cons, and all of the ugly aspects in a very short live session today. So thank you so much. Thank you for everyone for watching this video. Please follow Dr. Varun Agrawal on Instagram and visit his website ed4medus.com. So thank you, everyone, and I'll see you soon.
Thank you very much again, Dr. Adil.
Bye.